Can I introduce the first speaker in this masterclass? He's been chairing the previous sessions, Professor Dilip Nathwani, Professor of Infectious Diseases in Dundee.
Okay, thank you very much. Gavin actually has cellulitis, which is an irony. So I only got this message 2 days ago. So I apologize if it doesn't quite match the title that Gavin was meant to give, but I'll do my best and also do my best in the next 20 minutes. So really the objective is how, and what, I'm more interested in, rather than tell you what antibiotic you should be using, in a sense, just to think about the decision-making process that one needs to consider when you're making a difficult decision about somebody who's quite unwell with an episode of a complicated skin and soft tissue infection. It's a huge burden, as this paper, and it's a huge burden not only for the hospital setting, but also for a reason for admissions to a level 2 or level 3 critical care, high dependency unit or intensive care unit. So in a sense, we need to have an understanding of how we manage appropriately in a prudent manner, recognizing the things we've talked about in terms of antimicrobial stewardship. I think it's important to understand what infections I am talking about. Matthew talked about a whole range of infections. Some of them could be managed with oral treatment, but I'm talking about the right hand. Very severe infections, either deep-seated or requiring surgical infections, are often occurring in the healthcare settings in terms of surgical site infections and so on. So I'm really concentrating my presentation on the right-hand side. And these are the kind of typical patients that I'm talking about. They will require often surgery, they'll require source control, and they will require fluid therapy, and they will require a consideration about what antimicrobial you prescribe and how long for and the dose and so on. In a sense, this is my thinking of when I come across a patient with an aggressive, complicated skin and soft tissue infection, the thing that really drives my practice is how unwell they are, and how do you diagnose severity, what are their comorbidities, and where is the site of infection. Then it's about, could this be a resistant organism, understanding a little bit about my local epidemiology, the epidemiology of the region and the country that I work in, and then the other bits are possibly helpful in terms of, were they colonized with MRSA or a resistant pathogen before? Do I have some prior microbiology data that might allow me to predict the likelihood of the bug being a resistant pathogen? The kind of organism or the antibiotic am I using, is it going to penetrate into tissue? Is it going to kill the bug more effectively, i.e. is it cidal? Is it going to be an associated bacteremia and so on? So I think these in a way articulate what one must consider when they're making that difficult choice. And whilst this is a very busy slide, in a sense, we're trying to articulate a severity scoring system. There isn't one for skin and soft tissue infections. You can go to community-acquired pneumonia, you have the CURB 65 criteria. So in a sense, you have to guess, and you have to use a range of criteria to tell you how unwell systemically your patient is. And this is kind of what we tend to use, and we've published this in our own part of the world around an early warning score system, which is physiological abnormalities that most healthcare systems across Europe use to tell the nurse, the junior doctor, that how unwell systemically your patient is on this occasion due to an infection. And this is real-world practice. And what it shows is that whatever classification you use, as you become more unwell, you are more likely to die, okay? So it is in a sense telling you need to act promptly, you need to act effectively, and your choice of antibiotic is crucial. If you're at the milder stage of infection, if you get your choice of antibiotic wrong, it probably does not matter in terms of the outcome of the patient. You can adjust and they will get better. But if you're at the critical stage, your ability not to get the antibiotic, if you get it wrong, then perhaps you may become more compromised. So will the site help you? Roughly. So the site may tell you if the infection is following gastroesophageal surgery, what are the likely pathogens? If it's orthopedics, you're primarily concentrating on Staph aureus or coagulase negative staphylococci. If it's in urology, it's clearly gram-negative bacilli. So that, in a sense, will allow you to empirically target what route and what choice and spectrum of antibiotics you will use. So I want to present a very typical patient in my part of the world, and I suspect in many parts of the world that you live in. He had a perforated diverticulum by an abscess, and he was recovering in a very slow manner. He had the classic Scottish risk factor profile of type 2 diabetes, alcoholic liver disease, and he enjoyed a smoke. So he was the typical cardinal patient from my part of the world. And as you live in a hospital for all these weeks, recovering from a very complicated procedure, you will get exposed to antibiotics for a range of reasons, and then his wound becomes very aggressive, and as Ben would have said, pus was pouring out, and he became systemically unwell. So, what are the risk factors? Why did he become so unwell from a skin infection? And we have many systemic risk factors that will be familiar to this audience. In his case, what particularly his nutrition wasn't good, he had diabetes, he drank too much, and he had smoking. And those will be familiar in the sense of this makes this patient vulnerable to an aggressive skin and soft tissue infection. What tests would you do, and what would your diagnosis be? And if I give you some parameters, all these parameters tell you, in a sense, is that he is systemically unwell and he has got a severe sepsis syndrome. I was going to try to make this more interactive, but in 20 minutes that's not possible. But the parameters are telling you that he has beginnings of worsening of kidney injury and his organs are not working so well. So you really have to intervene effectively with the right antimicrobial treatment. But you need to think, is this a community-acquired infection? And that tells you something about what the bugs may be in terms of their resistance profile, or is this a healthcare-acquired infection? And remember, this man has been in hospital for quite some weeks and has had exposure to a range of antibiotics presently and also in his past. So really, the synthesis of that decision-making process should make you think, well, this is a surgical site infection. But that no longer is good enough. So you need to think it's an abdominal surgical site infection. That should alert you to the type of organisms that may be causing his infection. It's healthcare related. Again, that tells you a little bit more about the resistance potential. He has a range of comorbidities, but he did not have MRSA colonized. And you can check the lab system immediately to say, has this gentleman in his previous exposures to healthcare been colonized with MRSA? But we know he's been hospitalized for a long time, a driver for resistance, as well as I've said, previous antibiotic exposure. So in a way, we're trying to people to think it's not only a surgical site infection, it's a surgical site infection in a healthcare setting with severe sepsis that potentially could be due to a multi-drug resistant pathogen. What pathogen would you expect? Anybody, quickly? Nobody, is too late. I understand. Okay, so the pathogens, as Matthew has shown you and others have shown you, are very typical of what occurs. It's primarily gram-positive, Staph aureus, and then increasingly in these kind of patients with bowel surgery, you begin to think, could the coliforms potentially also take part? Could the anaerobic coliforms potentially could take part? And could this be a resistant pathogen? Because he has a whole range of risk factors. I showed you this slide before that still, despite what we think the majority of the patients who are admitted to hospital, not already in hospital and then becoming infected, will still have gram-positive pathogens. He has many risk factors, and we're trying to predict risk factors at the bedside. We don't know. We don't have microbiology till 24, 48 hours. How can you tell, could this be? Well, could he be previously colonized? Remember, he wasn't. He has been exposed to antibiotics, immediately a 10-fold risk. It is hospital onset, a 3-fold risk, and he has been hospitalized numerous times, again, increasing. So the likelihood of this gentleman, despite having no previous note of colonization with MRSA, is quite high. So how would you manage? I would have asked you, well, you do all the things you need to do to resuscitate the patient. We mustn't forget that. But would you give him just streamlined gram-positive treatment? Would you cover the possibility of MRSA? Would you go broader? Would you combine it with anaerobic cover? Those are all questions that this particular patient was raised. And we have lots of review articles really trying to give you a sense of that decision-making process. And I only put these 3 next slides up because they give you a bit of information of what I'm talking about. But at the bottom, you notice that the slide talks about the importance of severity assessment. And when you look at what you prescribe, you need to be aware of your healthcare system. Don't do what the Canadians say, as in this. Don't do what the people in Scotland tell you to do. Understand your microbiology so that you can form some kind of empiric advice for your local clinicians to guide them through this very difficult early empiric treatment decision-making process. So you see, in my part of the world, this is what our clinicians will be asked to follow. I use my words very carefully. I would like to tell them to follow this, but I initially just asked them to follow this. And in a sense, what we ask them to do is identify the severity, and we use very narrow spectrum agents, but we use them in combination. So they would get either flucloxacillin with a gram-negative aminoglycoside or vancomycin if we thought MRSA was a possibility. So this gentleman is a real patient. He initially got vancomycin because the clinicians who managed him at that time said that he had risk factors. He had to have something IV because he was vomiting. He had renal disease. He had peripheral vascular disease. He had kidney injury. But they could not resist giving him gram-negative and anaerobic cover because it's like heroin to a drug addict, because you begin to get agitated and you twitch if you don't give them that broad cover, because this patient was very, very unwell. So I don't have any problems with that. The key bit is that can you de-escalate in light of microbiology? This is European data that shows that the majority of patients who come into hospital, and if MRSA is suspected or proven, will either get a glycopeptide, vancomycin, or around a quarter may get linezolid. But sadly, what we find is when vancomycin is given, it's underdosed. It's not weight-based. And Fleming, from my lecture earlier, talked about underdosing and not weight-based dosing. We are doing patients harm by not giving them weight-based dosing regimes for very effective treatments in these very serious infections. What happened to this guy? Well, he had swabs were negative, but he then screened positive after hospitalization. His wound revealed MRSA, and he responded to the treatment of piperacillin, tazobactam, and vancomycin. Remember, start smart. So I don't mind the starting smart, but the focus is necessary. Now you have culture. What would you do? He's improving. You know it's MRSA. What would you do? Would it give it IV? So I'm going to give you some choices, and it varies on how you practice, whether you give IV, you give oral. What oral do you consider? Do you consider the penetration of that antibiotic in that area? Or would you think about Andrew's options around outpatient parenteral therapy? These are all pragmatic considerations that one needs to think about when you have this particular focusing bit of the strategy in terms of managing him. And this is a paper from the Medical Journal of Malaysia. So I read all the class journals from across the world to share experience. But I think this is a really good paper because it actually explored very busy clinicians about what gives them comfort about changing to oral therapy. Not to an ID microbiologist, but to real surgeons and physicians and internists. And it tells them that the majority that need to have clinical stability and things need to be going the right way, and they have got some microbiology to respond to. And in a sense, that's giving them the reassurance to do that. And we should switch them to oral. We don't have enough patients who are changed from IV to oral, despite all the criteria saying to you, this patient can now take oral therapy, and you're using a very bioavailable agent that will get to that wound in high concentrations to be able to deliver and treat that infection effectively. And we looked And we have published in relation to MRSA the number of opportunities to actual real practice. And it is underdone because clinicians have that comfort factor around IV therapy, despite now good validated criteria to say that you can actually change from IV to oral therapy if you satisfy the criteria that I talked about. And I think these are all interesting components of how we think about stewardship, because duration of therapy will drive resistance. And how can we encourage people to reduce that duration in relation to source control as well from IV to oral. This patient was switched to oral linezolid because he had a sulfur allergy. So cotrimoxazole was another choice. So we did manage to promote an IV to oral change, and that facilitated his discharge from hospital. And when you look at European survey data from 1,500 patients, you notice that a whole range of oral drugs are used to discharge patients in this particular case because it was due to MRSA. But if it's a gram-negative, you may use a very effective oral gram-negative agent that may actually promote their discharge from hospital. So in a sense, I think that these infections are a huge burden. I think we need to think about, will they have polymicrobial or unilateral type of sepsis or bugs? Is severity a very important criteria in that decision-making process by the clinician? I have less of a problem about starting broad, but I think the focusing bit is a key stewardship strategy. I think the dosing is poorly done, as real-world data is showing across the world, and I think we need to get our patients out of hospital quickly, either by changing to oral therapy, and if we're less comfortable with that, follow Andrew's OPAT strategy. In a sense, it brings forward many of the things that we've been discussing this afternoon. Thank you very much for your attention. And this is sunny Scotland as opposed to miserable London. So thank you very much. Okay.
Thanks very much, Dilip, for that very clear summary of how to choose an antibiotic and how to de-escalate and good antibiotic stewardship. Are there any questions? Can I ask one? This guy had his primary infection was intra-abdominal problems. So wasn't it perfectly reasonable to have him on broad-spectrum treatment as initial therapy? Yeah. I mean, I would have thought it was more likely to have been intra-abdominal bugs initially.
And that's why the site of infection would predict that in that slide. So yeah, our regime for that would have been vancomycin with gentamicin and metronidazole. But I think people prefer pip/tazo because it's quicker and it's broader. But yeah, I think it was very reasonable practice.
But then the important message is, reviewing at 48 hours and de-escalating.
It's the focus bit, yeah. And I think that you can't give anybody a difficult time for doing what they did. And I think actually it was quite well thought out. But it's then the strategy of focus is quite important. So that's a good point.
Very good, thank you.
Okay, thank you.
If there are no more questions, I'll hand over to my co-chair to